that in the year 1900, which was the same year my grandmother was born, the average life expectancy for a woman in the United States was 40 years of age. Why, do you ask? Because the same cause of death that is the leading cause for maternal mortality worldwide was the leading cause of death then. Postpartum hemorrhage results in a worldwide deaths occurring in about 10% of all births. It accounts for 130,000 maternal deaths annually, and it also accounts for 30% of all direct maternal deaths. What are the new Joint Commission standards regarding postpartum hemorrhage? There are a number of PCO6 measures, one regarding hemorrhage and one regarding preeclampsia. This is PCO601 from the Joint Commission for Perinatal Safety in 2020. The Joint Commission, recognizing that postpartum hemorrhage is a leading cause of maternal mortality and that the United States ranks 65th in industrialized countries in maternal mortality, put in place some things that hopefully will reduce the likelihood of harm related to maternal hemorrhage. There are 13 new elements of performance which will be applicable to all hospitals who are accredited by the Joint Commission, which are most hospitals in the United States. These new requirements are within the provision of care, treatment, and services for women with postpartum hemorrhage. They are designed to improve quality and safety of care provided to women in all stages of pregnancy and postpartum. So let's look at some of these elements of performance. You need to complete a hemorrhage assessment on admission. Why? This is extremely important. An hemorrhage assessment means that you recognize patients who may be at risk for hemorrhage prior to them having an event. You need to develop a stage-based management plan. What happens when a woman bleeds a little versus what happens when there's a lot of bleeding. One of the most important things in this assessment from the Joint Commission is the placement of standardized hemorrhage carts on your labor and delivery unit, possibly your antepartum unit, and your postpartum unit. These carts are to be checked off regularly and have medications that actually help in treating patients with postpartum hemorrhage. The other plan is to conduct drills annually. These drills include simulation, which means that all people involved, from the blood bank to anesthesia to even the unit clerk, need to be involved to make sure that the best care is delivered to our patients. And when patients have a hemorrhage, we're to review these cases to determine what we could have done better and whether or not we were proactive in identifying that the patient was at risk. We also need to provide education to patients and families. For example, if your hospital has an ACRETA program, patients and families need to know what to expect regarding hemorrhage, the need for transfusion, the possibility of other operative events in order to make sure that the patients are well informed. And postpartum, we need to make sure that patients and families know what to look for so they're aware of what they need to do to come back in and be cared for. So these are our key ideas, the objectives I was talking about. We're going to talk about the significant impact of obstetrical hemorrhage on maternal mortality and morbidity and the most common risk factors. We're going to do a staged approach to assess and recognize and treat obstetrical hemorrhage. And then in the end, we're going to talk about racial disparities, looking at through the lens of equity so we can provide better care for our patients. We're going to talk about the significant impact of hemorrhage on maternal morbidity and mortality and the common risk factors. How do we define postpartum hemorrhage? The definition of postpartum hemorrhage is early postpartum hemorrhage, and there's a cumulative blood loss of 1 liter, that's 1,000 milliliters, or blood loss associated with signs and symptoms of hypovolemia within 24 hours. This does mean that it does not matter whether the patient has a vaginal delivery or whether they have a cesarean section. A loss of 1 liter of blood or signs and symptoms of blood loss should be defined as postpartum hemorrhage. Cumulative blood loss between 500 and 999 milliliters alone should increased supervision, and potential interventions for these patients as clinically indicated. These patients then become at-risk patients so that we don't move these patients to a lower level of care, such as maybe our postpartum floor, without again evaluating them to make sure that their risk for hemorrhage has decreased and resolved. Obstetrical hemorrhage, as we talked about, is a leading cause of maternal morbidity and mortality worldwide. Well, maybe one of the reasons for that is we have not been able to really decide on what a definition would be. So ACOG defines postpartum hemorrhage as loss of 500 cc's after a vaginal delivery or 1,000 cc's after a cesarean section. Severe postpartum hemorrhage, as defined by ACOG, is 2 to 2.5 liters after delivery. The World Health Organization declares postpartum hemorrhage is 500 cc's after delivery. It doesn't say what type of delivery within the first 24 hours. And then severe postpartum hemorrhage as a liter after delivery within 24 hours. Antepartum blood loss as of 24 weeks gestation, that is antepartum hemorrhage. And then there's primary postpartum hemorrhage. Those patients who bleed at delivery or within the first 24 hours. And then secondary postpartum hemorrhage. They can be anywhere from up to 6 weeks postpartum. And keep in mind that many of our patients who bleed within this period may have other bleeding issues that we need to address. And then, of course, there is a higher level hemorrhage in either the antepartum or postpartum period of 2 to 2.5 liters. What are our risk factors for postpartum hemorrhage? A prolonged or augmented labor, and can I add to that an induced labor? Because often induced labors are also prolonged and augmented. As we just talked about in that patient education, abnormal placentation or retained placenta. Lacerations, especially those associated with an operative vaginal delivery. A large infant. Keep in mind that a macrosomic or a large infant also usually is associated with a larger amount of amniotic fluid. This increases the risk that the uterus is overdistended and may not contract back down after delivery. Abruption, which not only causes hemorrhage, but also consumes coagulation factors that increase the risk that the patient will continue to bleed. Hypertensive disorders, which also affect platelet dysfunction, and anybody who's had a history of a prior postpartum hemorrhage. I took care of a patient once who hemorrhaged on her first pregnancy. We thought we were going to have to do a hysterectomy. Did not. She hemorrhaged on her second pregnancy. We thought we were going to have to do a hysterectomy. We did not. On her third pregnancy, I took all types of precautions to make sure she did not hemorrhage. She went back to the room, and 1 hour later, she hemorrhaged. And that time, we had to do a hysterectomy. So prior postpartum hemorrhage is really something that we need to take into account when we look at risk factors in history. One of the things that is affecting us in the South is obesity, because it makes it harder for us to be able to massage the uterus. High parity, when a patient has more than 4 children, the uterus again may not contract back down as well. Being Asian or Hispanic, with that population is increasing. People who all of a sudden just come in and deliver their baby within an hour, which people consider to be lucky, but it also increases your risk of postpartum hemorrhage. Any uterine overdistension. I recently just got another set of quadruplets. This will be my 5th set of quadruplets I have taken care of, along with this set of quintuplets. That is significant uterine overdistension. And when I decide to plan for her delivery, I'm going to plan for postpartum hemorrhage. Uterine infection. That prolonged labor that you did, that now is infected, that also, now we have 2 risk factors, and then drugs that cause uterine laxation. Because of hypertensive disorders and our patient population and the use of magnesium, we're seeing more patients who are at risk for postpartum hemorrhage. Name a common patient that may be at risk for postpartum hemorrhage in your institution. I know in my institution, I just told you about the quads, I told you about the accreta. They're patients with fibroids. All of those patients are at risk. What are the causes of postpartum hemorrhage? Uterine atony, still number 1. Deliver the baby, everything's going well, but the uterus just will not contract down. That becomes a problem, and so therefore managing uterine atony is something that is very important to understand. trauma and lacerations. We talked about the use of operative vaginal delivery, or that precipitous delivery that then also tears her vaginal and her perineum, vaginal area and her perineum in a way that makes it difficult to repair. Retain products of a placenta or products of conception. We recently had a patient who had a incomplete termination of pregnancy. Those patients come in and have a significant amount of hemorrhage. Abruption. Abruption does a couple of things that I want us to think about. One is it takes care, there's a coagulopathy or a coagulation disorder that comes with that. But also when you're abrupt and the placenta is still in, blood goes into the uterine fibers, and those uterine fibers is called a Cuvillare's uterus, can no longer contract. So an abruption in itself increases the risk that the patient is going to have significant bleeding because she cannot clot and her uterus cannot clamp down, so then you get uterine atony. Uterine inversion. You know, those of us who are in training hospitals, sometimes people put a little bit too much pressure on the placenta when you're first learning to deliver, or sometimes you're in a hurry, you just want the placenta to come out and you pull a little too hard, and the uterus, actually the placenta is still stuck to the uterus, so it takes the uterus and turns it inside out. That again is another cause of postpartum hemorrhage and should be dealt with very rapidly. And then of course the increasing abnormal placentation. Did you know that if you have a cesarean section and you're on your fourth one, that your risk of having abnormal placentation is 44%. So that means that if some patient comes into your office and she's on her fifth baby and she's had 4 previous cesarean sections, it's about 50-50 that she's going to have abnormal placentation for that delivery. Again, we talked about hemorrhage versus trauma. So let's think about things that are trauma. Uterine atony, birth canal trauma, retained products of conception, and then placenta previa or accreta. And things that aren't trauma, things that we can't really control, such as the placental abruption or an amniotic fluid embolism. Another significant cause of uterine atony, and due to the coagulation factors associated with an amniotic fluid embolism, also another reason why the patient may have hemorrhage. Well, how can we take care of these? TIP-QC is associated with quality and data and management. So now we're going to look at some data inside our state and around the United States. In the state of Tennessee, from 2017 to 2018, there were 44 maternal deaths out of about 75,000 deliveries. That makes us 43rd in the United States in maternal mortality. Our leading cause of death was cardiovascular conditions, followed by hypertensive conditions, followed by hemorrhage. There were 6 deaths in Tennessee in patients who actually bled to death at the time of their delivery. That's a pregnancy-related death. However, around the world, the incidence is about 4 to 6%. It's very difficult to establish. There's no universal definition, as we've already talked about, and an inaccuracy in estimating blood loss. Most importantly, the timely recognition, especially in lower resource areas, appropriate resources and responses are critical for preventing death. So when I was in Ghana, I went to a village. I was very interested in how they took care of their postpartum hemorrhage. So they took me to their area where they would then put their patient on a cart and carry her into Accra, which was the city. Very interestingly, all they had to deal with postpartum hemorrhage was 1 bag of IV fluid. And so it's really important to understand that worldwide, not only getting people to recognize, but providing appropriate resources can reduce a number of these maternal hemorrhage deaths. Well, let's look at cause of deaths in the United States. As you see here, hemorrhage accounted for about 11 of those deaths. And in fact, besides cardiomyopathy and other cardiovascular conditions, hemorrhage still was a major cause and a major contributor to maternal mortality in the United States. So if you look at the 3 most causes of pregnancy-related deaths by the time related to the end of pregnancy, during the day of delivery, hemorrhage is a leading cause of death. But please note that 1 to 6 days postpartum, hemorrhage is still a leading cause of death. behind hypertensive disorders and infection. Again, if you look at this data, you will see that hemorrhage the day of delivery and 1 to 6 days postpartum is almost equal. Then the rate of death falls off, but it is not zero, especially between 7 and 42 days postpartum. There's still about an 8% risk of the maternal deaths caused from hemorrhage in that time period. What does this tell us? This means we need to continually assess for postpartum hemorrhage and educate our patients and families on when to bring that patient back to the hospital. The California Collaborative looked at what were the issues that really prevented us from doing a good job with hemorrhage. And one of the things for both hypertension and hemorrhage was the delayed response of clinical warning signs. Most importantly, there were some other things like failure to consult or lack of continuity of care or misdiagnosis. But mostly it was our delayed response. And why do you think this might be? Because obstetricians are used to seeing a large amount of blood. So we're like, well, it looks okay. Well, maybe she's not bleeding too much. Well, I think it's going to stop in a minute. We tend to rationalize simply because we are used to seeing patients bleed. This leads into a delay in clinical response. And so it's important for us to have a standardized approach. If we look at from the CDC, the rate of postpartum hemorrhage in the United States, postpartum hemorrhage with obstetrical procedures to control hemorrhage have gone up significantly, as well as postpartum hemorrhages with blood transfusion. Now, some of that may be because around 2010, we really began to work on postpartum hemorrhage. So I always point out that an increase in blood transfusion and an increase in procedures to control hemorrhage may not really be that bad. But we still need to continue to look at our data to determine exactly what we're doing and why our rates of hemorrhage have increased. Now, these are trends in severe maternal morbidity. Again, what is driving this is mostly blood transfusions. Again, some of this is because we become more aggressive with giving blood. The other thing, though, as we drill down into many of our severe maternal morbidity data, is that many of our patients are not optimized prior to delivery, and they have an increased risk for anemia, which then leads to also us having to give an blood transfusion in order to stabilize the patient. What is the magnitude of the problem? The leading cause of maternal morbidity and mortality is the failure to recognize excessive blood loss during childbirth. Women die from obstetrical hemorrhage because effective interventions aren't initiated early enough. This is the critical pathway to a poor outcome. Symptoms are not recognized, or the assumption is the symptoms aren't significant. Keep in mind we deal with a young population. And I always tell people young populations are like dealing with the little Swiss Alp man on The Price is Right. The man goes up to the top, you don't get the price right, and then he falls off on the cliff. So often by the time we recognize what is going on with the patient, they're at the top of the hill and then getting ready to fall off the cliff. This is due to our delayed diagnosis. While the patient wasn't bleeding, delayed treatment. We didn't get the blood products up fast enough. This can cause severe maternal morbidity. Patient ends up in the ICU. She doesn't die, but she has renal insufficiency. She has to be on dialysis until her kidneys work because they were not perfused well for several hours while we did not recognize her hemorrhage. And then, again, the ultimate or the last step is maternal death. So what are the key elements of the hemorrhage protocol? Help assigns personnel to treat the patient due to the changing status. When a patient begins to bleed, we need to be able to activate more people to come to the room. Additional providers, including anesthesia, an additional senior surgeon, especially if we anticipate the patient may need a hysterectomy. And we also need to call other support people to the room and let blood bank know that we're in trouble. We want to eliminate barriers for rapid transfusion of all components necessary for treatment. One of the ways we eliminate barriers actually is to recognize that we are in trouble, we call for help, and we then institute protocols that assist us in eliminating these barriers. We want to facilitate access to all items that are needed, equipment and supplies. We talked about those PCO6 measures and the fact that we have a standardized hemorrhage cart. Well, if everything is on the cart and everything is standardized, we know where things are and we can respond quickly. We want to resuscitate based on current and future or expected blood loss. We want to transfuse not only blood products but clotting factors in order to prevent disseminated intravascular coagulation. And the protocol should be reviewed as a code. Code red. That means you are losing blood. Or any type of thing on your unit that lets you know that a hemorrhage is occurring. And then we want all exposed education regarding goals and the role. All cases, whether the barriers, whether or not there was access or resuscitation, need to be reviewed. And any time that we see that there's a systems error, we need to do everything we can to correct it. How do we then kind of come up with a stage-based approach to recognize and treat obstetrical hemorrhage? First thing, we need to identify the source of bleeding and administer drugs to assist with this. Where are our drugs going to be located? Most of the time, some of them are going to be located on that hemorrhage cart. And if in our system, we need to know that those drugs that aren't located on the hemorrhage cart, they can be overwritten in our system. We're going to apply direct pressure to the uterine cavity. If you have uterine atony, applying pressure is one of the best ways to stop the uterus from bleeding. And in fact, I tell people all the time, apply pressure and roll your uterus down, often will tell you whether or not any other further interventions are going to work. We want to control the blood supply to the uterus. We can do this through a number of ways. We can do a uterine artery ligation. We can also do other things such as placing our hand on the aorta in extreme circumstances. But this helps to control the blood supply to the uterus. We can also raise the uterus up and hold it very tightly out of the pelvis. That's another way to control that blood supply. After we've done that and we rolled our uterus down, we can place uterine compression sutures. It doesn't matter. You can do B. Lynch. You can do Heyman, whatever is used in your institution and whatever is available to work quickly. We can consider putting in a balloon or things of that nature to help with bleeding. But last but not least, we never need to forget that step 5 is to perform a hysterectomy. So we need to be able to go through steps 1 through 4 very quickly in our mind and make a decision on whether or not the patient needs a hysterectomy, as this can be life-saving. Well, let's look at some planned interventions. Let's do our risk assessment on admission. The patient comes in, she has twins, she has preeclampsia, and this is her 6th pregnancy. I would say that all of you watching this video would say, oh, she is at risk. Then we want to avoid delay. Now that she's at risk, we've noticed she's at risk, so we've already prepared. And now when the patient begins to bleed, we begin our stage response. We want to then give medical therapy because we've already anticipated that she was going to bleed, and then order our labs early to make sure that we are on top of what is going on with the patient. We want to also figure out how much blood product to use. As I said before, estimated blood loss is low. Delay has likely occurred, and you never need just 1 unit. Now, you may need 1 unit when the patient is postpartum and she started out with a hematocrit of 24 and now it's 20. That's different. In postpartum hemorrhage, you need more than 1 unit, and you need to prevent DIC, because if we do not, then that increases maternal mortality. DIC basically means as you put red blood cells in, red blood cells come back out because the patient cannot form a clot, and so therefore it becomes very difficult for her to then stop the bleeding process. Again, we want to use a hemorrhage pack, an OB hemorrhage pack, and we want to consider using things like a balloon, and we want to know how to use the balloon while we're waiting, again, as our processes occur. Blood use, order our blood products. We know that our use is low. We underestimate our blood loss. We need to temporize, pack the uterus, know how to pack the uterus. If you don't have a Bakri balloon, you can use Kerlex. anything to temporize and decrease your blood loss and reduce the risk of DIC. Again, this is the hemorrhage risk assessment. Low risk, you can draw a clot tube, although I know many hospitals draw a type and screen. No uterine incision, no history of postpartum hemorrhage, less than 4 vaginal deliveries, no bleeding disorder, and a singleton. Now, we've already talked about some of those at-risk patients: history of postpartum hemorrhage, previous cesarean section, gram multiparity, multiple gestations, large fibroids, infection, and magnesium sulfate use. And then the high-risk patients, you really need a type and cross. The CRETAs and the previous. And then look, as we talked about, some patients aren't well prepared. When a patient presents with a hematocrit less than 30 and has other risk factors, she's already at risk, she's already at high risk, which is something that we often don't recognize. Anybody who has a coagulation defect, anybody with antepartum or hemorrhage on admission, low platelets less than 1,000 K, and then symptoms of stage 3 hemorrhage, which we're going to talk about in a minute, and or unstable vital signs. Those patients need a type and cross, and probably for more than 2 units. For anybody with unstable vital signs, I probably would go ahead and enact a massive transfusion protocol. Here's your readiness. Every unit, cart with supplies. What's on your cart? Retractors, sponge forceps, sutures, vaginal packs as we talked about, uterine balloon, curette, long needle holder, anything that you're going to need for hemorrhage from medications, Pitocin, Hemabate, Methergin, Cytotec, all of those things need to be on your hemorrhage cart. And then available on your floor, the ability to start an IV, any type of extra sterile gloves. And I always think that when we're talking about this, we need to make sure that we have the numbers for the unit clerk and anesthesia available so that no one has to leave the room to look for those types of things. Now, what are our goals? Remember, we just talked about stage 3 hemorrhage. We want to maintain a diastolic blood pressure of greater than or equal to 45 millimeters of mercury and a systolic blood pressure of greater than or equal to 85. Why? That gives us a mean arterial pressure that helps with kidney perfusion or renal perfusion. Now, there's a caveat to this in where your kidneys may not be perfused in a patient who has had hypertension already. So if the patient came in with a blood pressure of 200 over 100, you may want to raise this a little bit in order to make sure that you have appropriate renal perfusion. You want to receive and use appropriate blood products. You want to keep your hematocrit greater than 24, but keep in mind that getting labs is not very helpful, as your hematocrit actually decreases, as your hematocrit actually takes 3 hours to equilibrate. So if your hematocrit's 20 and you're still bleeding, your hematocrit's more like 17. So you need to think about that when you're actually getting your labs. A fibrinogen greater than 100, although I personally like it greater than 200. An INR less than 1.4, platelets greater than 50. And you don't want to make sure your patient is not cold and she's not acidotic. Why do you say these two things matter? Because these cause vasodilatation, which means the patient can't clamp down and increases the risk she will continue to bleed. Here's your hemorrhage protocol. All patients at all times are in one of these stages. 0, normal intrapartum and postpartum course. Stage 1, bleeding greater than expected. We see stage 1 almost all the time in twin or multiple gestations. Stage 2, requiring more than 2 urotonic agents in addition to oxytocin and not responding to usual measures. When a patient is in stage 1, you just call out and say, hey, I think I may need help. By the time she's in stage 2, you have already called out and said, hey, I need help. Stage 3, this is the point where we really don't want to get to, if we don't have to, a blood loss of greater than 1,500 cc's or abnormal vital signs. By this time, if you've not called for help, you really need to mobilize all your forces, because stage 4, the recovery stage, or we can continue on to having more blood loss, which means that the patient will not recover, and that's not where we want to go. Blood loss, 1 gram equals 1 milliliter. So there's a couple of things you can do. You can use a C-section drape, and you can make sure that you look at blood loss that way. You can use an equilibrated under the buttocks drape, where when the blood goes into the drape, it kind of tells you exactly how much blood there is. And then there's weighing, or what we call quantitative blood loss, where we actually take a Chuck's pad, we put it on a scale. We know the weight of the Chuck's, let's say, is 2 grams, and now this weighs 500 grams. So that means we've lost almost 500 milliliters of blood in this Chuck's. All of those things are very good ways to equilibrate blood loss and make sure that you have an idea of what is going on with the patient. Now, what are our medications? Everybody knows oxytocin. Now, oxytocin, you said 10 to 40 liters, and 500 to a liter of solution. Some places run their oxytocin slower, some run them, open it up and run it faster. Whatever you do, remember that oxytocin can be associated with blood pressure dropping, so a rapid infusion of oxytocin can cause hypertension. There's also methogen. Methogen is 0.2 milligrams IM, and you can repeat it, but you cannot give it to patients with hypertension. Caveat: if your patient is hypotensive and but has been hypertensive in the past, methogen is not always contraindicated. 15-methyl prostaglandin F2 alpha, 250 milligrams IM. You can repeat this every 15 minutes to up to 8 doses. Now, keep in mind, this is a pretty potent uterotonic. I have never seen it work after 3 doses. And in fact, I was once training a fellow, and he had given 10 doses, and he said, I think the patient is going to stop bleeding. And I said in my mind, she is. She's going to stop bleeding in just a minute, but that's not what we're going to be wanting to look for, because she's going to have cardiovascular collapse. Avoid it in patients with asthma, and use with caution again in patients with high blood pressure. Cytotec, you can use it rectally, you can use it sublingually, you can use it PO. Either method is appropriate. And I always tell people, when you're having a hemorrhage, just make sure that you're using all of your uterotonics. Now, one of the things that was really important for us to use is transacetic acid. Transacetic acid has been shown to reduce blood loss within 24 hours in patients who have postpartum hemorrhage, and to reduce maternal mortality. You want to give 1 gram in 100 milliliters of normal saline over 10 minutes, and you want to repeat it after 30 minutes. And then again, your other interventions, some type of uterine packing, your Bakri balloon or any other balloon that you have, EB, some type of compression suture, uterine artery ligation to control blood flow, and then, of course, hysterectomy. When we look at transacetic acid, this is something we really need to be aware of and know how to use. This is the WOMAN trial, which is a randomized controlled double-blinded trial. They administered transacetic acid within 3 hours of delivery, and what they demonstrated, it reduced maternal mortality and morbidity. There was decreased bleeding, decreased need for a laparotomy, but there was no increase in thrombotic complications. As we talked about previously, you give 1 gram with a repeat dose in 30 minutes if the hemorrhage reoccurs in 24 hours. This is important to know because you may have given 1 gram at 2 p.m., but now your patient is on the floor at 6 p.m. and bleeds again. The patient can then get another gram of transacetic acid. The immediate treatment resulted in a 70% improvement in survival. And for every 15-minute delay, there was a 10% decrease in survival benefit. After 3 hours, there was no benefit in giving transacetic acid. So what does this mean? This means that you should give it early in the process. In some countries, I would recommend it as one of the first line things that we give because it's easy to give. And in our particular hospital at Ascension, when we call for the massive transfusion protocol, we also are going ahead and infusing transacetic acid. Now, there are limited evidence that prophylactic use in high-risk patients reduces postpartum bleeding or the need for transfusion. And in fact, a recent study, a recent randomized controlled trial, confirmed that giving prophylactic transacetic acid, while it reduced blood loss, it did not really reduce the need for other items such as transfusion. ACOG and the Society of Maternal Fetal Medicine also had some ideas on comprehensive hemorrhage protocols to improve patient safety and reduce blood product utilization. So one of the things is we want to resolve our hemorrhage early, which reduces the risk of us using blood products. We also want to identify our anemia prior to the patient coming in, which again will reduce the risk of using blood products. So what is the recommended use? ACOG uses 6 packed red blood cells, or if you don't have type-specific blood and the patient is bleeding, O-negative blood will work. 4 units of FFP, 1 unit of platelets, and 5 to 10 units of cryo. California Collaborative did not include cryo, which one does not have to consider. Cryo is useful in that it does replace clotting factors with a smaller volume. So therefore, if you are worried about volume, such as an amniotic fluid embolism, this may be something you want to put in your product release or your massive transfusion protocol. Almost every other institution used 6 units of packed red blood cells, 4 units of FFP, 1 unit of platelets, and 10 units of cryo. Interestingly, some places use 2+ units of blood, 6 units of fresh frozen. There are a lot of the information coming from the ground on the battlefield and in trauma that 1-to-1, whole blood, 1 unit of packed red blood cells, 1 unit of fresh frozen, as you transfuse, reduces the risk of disseminated intravascular coagulation. And it is indicated when your hematocrit is 20 to 23, when you have an INR greater than 1.5 for fresh frozen, platelets less than 50,000, and a fibrinogen less than 100. Keep in mind that if you're actively bleeding, if you have a hematocrit of 20 to 23, it is much lower than that value. This is the World Health Organization recommendations for transacetic acid. Again, it points out it should be available at all times in labor and delivery and postpartum of facilities providing emergency obstetrical care. It is cheap. Treatment delay appears to reduce the benefit, as we talked about, and the fixed dose that we talked about. So it is important to remember that the early use of IV transacetic acid is very important in our protocols. What type of information is out there for us to develop our protocols from? Here's a list from ACOG, California Collaborative, from AIM, the Council on Patient Safety, from Florida, and from your own Tennessee Perinatal Quality Collaborative. There are bundles that you can use in your hospital to improve outcomes for your patients with hemorrhage. The Safe Motherhood Initiative means that we should recognize and prevent in every patient. That means we should screen early. We should identify those patients at risk. Every unit, whether you do 500 deliveries a month or whether you do 50 deliveries a month, or whether you do 20 deliveries a month, should be ready for postpartum hemorrhage. There should be a staged response in every hemorrhage, and there should be reports and a system learning in every unit. What went well, what did not go well, what in the system do we need to fix to make it better next time. This is the ACOG Safe Motherhood Initiative bundles. It has slide decks, visual aid posters, checklist, algorithms, risk assessment tables, medication dosing tables, and debriefing forms. Everything you're going to need on your unit to meet those PCO6 measures from JACOB. Again, this is the Council on Patient Safety with their bundle, and AIM also has a bundle that can be useful in caring for your patients. The California Collaborative has a flow chart that I actually just love. And I feel like it should be in every operating room and every obstetrical delivering area. And what I really like about this flow chart is it tells you when you're in stage 1. Now, you're here, you have already hit stage 1. You've lost that 500 cc's from a vaginal, 1,000 cc's from a C-section. It also then gives you some plans and some guidelines of where to go next. So even if you are not used to having hemorrhage very often, somebody can go over and say, hey, this is where we need to go. This is how we need to manage this patient. The California Collaborative also has a debriefing tool for you to use after you've had your event. Did help arrive timely? Did the team members know what was going on? Medications are timely? Was a device placed? In some hospitals, especially in our hospital that is very specialized, A lot of times, if you need ancillary services, they don't even know where labor and delivery is. So it's very important to include the team as you're going forth to make your safety bundles for your hospital. This is from A1. These are the risk assessments. This is what we talked about at the beginning, patients who are low risk, medium risk, and high risk. Another resource you can use and take from the A1 website. Here's a flow chart looking at the management of postpartum hemorrhage. One of the things I want to point out here is after identifying it, the communication of the obstetrical team with the anesthesiologist, the use of uterotonics, and where the failures come in. If you don't have the ability to do conservative management, what we need to do is activate what we have, activate the blood that's in our hospital, and proceed with definitive management. Now, as we finish this lecture, we're going to talk a little bit about racial disparities. What are the disparities in obstetrical outcome of hemorrhage? And did you know that black women are more likely to have problems or to die from postpartum hemorrhage? This is a retrospective study of almost 40,000 women. The risk for severe morbidity was significantly higher in non-Hispanic black women who experienced hemorrhage, and this was the risk for non-Hispanic white women, Hispanic women, and Asian women, respectively. The death for non-Hispanic black women was 121.8 per 100,000 deliveries versus 24.1 per 100,000 deliveries for non-Hispanic white women. That's almost, if you really look at that, an 8-fold increase. Black women were more likely to experience postpartum hemorrhage, and they were more likely to experience the complications of postpartum hemorrhage, including DIC, which is in graft A, transfusion, graft B, and hysterectomy, graft C. So what are our take-home points? Postpartum hemorrhage is defined as excessive bleeding after a vaginal delivery or cesarean section that can be associated with hemodynamic instability if the bleeding is severe. Every center that performs obstetrical care should have a protocol in place to manage patients with obstetrical hemorrhage. Usual signs of increased heart rate or tachycardia and hypotension associated with severe bleeding may not manifest early due to the relative hypervolemic state in pregnancy. Remember my illustration. We're on the cliff and we just fall off. Occult bleeding, that is bleeding we may not always see, can occur behind your placenta, sometimes in hematomas in the pelvis or in the retroperitoneal space. And many women have predisposing factors leading to the development of postpartum hemorrhage. Therefore, we need to have ongoing assessment in the antepartum, intrapartum, and postpartum period. Now, the most frequent cause of postpartum hemorrhage is uterine atony, as we talked about, 1 in 20 deliveries. And the risks include overdistension of the uterus, such as in polyhydramnios or multiple gestations, retained placenta, uterine muscle fatigue, i.e. a prolonged induction, and the use of halogenated anesthetic agents when we have to use general anesthesia. Disseminated intravascular coagulation is associated with placental abruption, HELLP syndrome, acute fatty liver, intrauterine fetal death, not often, but it can be, sepsis, and most importantly, amniotic fluid embolism. Keep in mind, in an amniotic fluid embolus, you don't have to have all of the cascade, i.e. the patient doesn't have to pass out or have her heart stop beating in order to have some of the bleeding that can occur from an amniotic fluid embolism. Just recently, we had a patient who kind of pulled her uterine artery, had an amniotic fluid embolism. She coughed and dropped her blood pressure. Then she recovered, but she lost 2,500 cc's of blood before they got to the OR. So the hemorrhage was still there. Early use of transacetic acid has been shown to reduce maternal mortality and morbidity. Aggressive resuscitation improves outcomes. Transfusion should be considered early. I always hear people say, I hate to give blood. You should not hate to give blood. You should want to stabilize your patient, and you want to transfuse 1-to-1 packed red blood cells to plasma to prevent coagulopathy. Now, last but not least, placenta accretive spectrum is an abnormal invasion of the placenta into the uterine wall. It is associated with significant morbidity and mortality. If you identify a patient with this in your practice, you need to send them someplace who has a standardized approach, comprehensive multidisciplinary care, and people who are accustomed to managing placenta accreta spectrum. Most of these are identified by ultrasound, and we are now putting in place some ultrasound guidelines in order to make identification easier, so these patients do not deliver in places that do not have that type of experience. I thank you for your attention today, and I hope this lecture has been helpful to you as you develop your programs and protocols to manage obstetrical hemorrhage and to improve outcomes for mothers and babies across the state of Tennessee.